Drops are falling, they pitch on their head. Their uniforms are heavy and wet. The shoes full of slurry. There's no time to worry. There's no time to brood over it. Troops moving forward, spring to their arms. They're ready now to fire again.
Is there anything you guys need help with today, other than
Afraid of being bugged,
since we've been doing
afraid
this
of
together?
running circles again. When I'm on my road again, on the road I walked before. When I'm on my road again, on the road I walked before.
Good Friday afternoon, everyone. I'm Araceli Revote. I'm the Chief of Staff for Geriatrics and Extended Care for the South Texas Veterans Healthcare System in San Antonio, and happy to be here. Our next topic is on biomarkers of Alzheimer's disease. Is this better? Okay. And for, of course, our disclosure, I have no relevant financial relationships with commercial interests to disclose. Our objectives for this talk are to identify the established biomarkers for Alzheimer's disease. Oh, I'm sorry. To describe the demographic and clinical characteristics of Mexican Americans with Alzheimer's disease, and to identify the divergence of potential blood biomarkers seen in Mexican Americans and non-Hispanics. So throughout the talk, basically we're going to be talking about plainly on Alzheimer's disease. An estimated 5.2 million Americans have Alzheimer's disease, with the majority, about 5 million, comprise the older onset type, and approximately 200,000 people with the disease are younger than 65 years old. And these people are considered to have the early onset Alzheimer's disease. As mentioned in previous lectures, by the year 2050, it is estimated that the number of individuals with Alzheimer's disease worldwide will quadruple from the current number of 36 million people. Now, the pathogenesis is complex, as again previously described, and the exact mechanism is unknown. And to date, there is no single test prior to post-mortem examination can confirm that a person suffers from Alzheimer's disease. Therefore, there is a strong need for accurate and sensitive tools for the early diagnosis of Alzheimer's disease. Now, as I mentioned earlier, the majority of Alzheimer's disease patients are of the older onset and are caused by 81 of a number of single gene mutation on chromosome 21, 14, and 1. And the genes those are the genes that encode amyloid precursor protein, presenilin 1, and presenilin 2, respectively. These genes have autosomal dominant pattern of inheritance and almost complete penetrance, about 85%. Thus, the presence of mutation is tantamount with disease, while luckily, this occurs rather rare. Now, the genetics of what you call late onset Alzheimer's disease is perplex, and the only confirmed risk factor for load remains the apolipoprotein E4 allele on chromosome 19. The ApoE gene provides the blueprint for a patient that carries cholesterol in the bloodstream, and everyone inherits one form of apolipoprotein E gene from each parent. Now, the E3 forms the most common, with about 60% of the US population. And there's an estimated 20 to 30% of individuals in the US that have 1 to 2 copies of the epsilon 4 form, and approximately 2% of the US population has 2 copies of E4. So how do we define biomarkers? Biomarkers are defined as predictor of normal biological processes, pathogenic processes, or pharmacological responses to therapeutic drugs. And biomarkers would allow for a less invasive and more accurate diagnosis in the antemortem period, and may facilitate early diagnosis, which is challenging given that there are no signs or symptoms unique to Alzheimer's disease. More importantly, they may allow for the identification of individuals with preclinical Alzheimer's disease. Now, as we all know, preclinical Alzheimer's disease are the one that have some symptoms but not quite there yet, and we don't know who these people are that have mild, probably cognitive impairment that will progress eventually into a full-blown Alzheimer's disease. Now, we know, at this point, we know there are 5 well-established Alzheimer's disease biomarkers. 2 are CSF, so cerebrospinal fluid analytes that measures abnormal protein aggregates. The defective clearance of beta amyloid from aberrant cleavage of amyloid precursor protein results in its accumulation initially into a soluble oligomers and then larger soluble fragments, which precipitates as amyloid fibrils. And you hear about Alzheimer's disease all the time about beta amyloid and fibrillar tangles and things like that. So that starts as the amyloid fibrils. Now, tau aggregates as part of filaments that are twisted around another, and this later on deposits, which interferes now with your cellular function. So these are the 2 ones that are from CSF. Now moving on to the other 3 known or established biomarkers. We have the MRI scan, which may detect atrophied sensible brain areas. So you heard from previous talks about the parts of the brain that gets atrophied when you get Alzheimer's. Second one is the Pittsburgh compound B, which is actually a PET scan, and this compound B is a tracer. Pittsburgh compound B uses a substance that crosses the blood-brain barrier and binds selectively to the beta amyloid deposits. Remember, we described earlier the beta amyloid getting into this, it accumulates. And now, basically, this tracer will then is combined with that amyloid. And now, when you do the PET scan, that will light up. So it crosses the blood-brain barrier and then binds selectively with the beta amyloid deposits. And lastly is this fluodeoxyglucose, which used to quantify abnormal neuronal glucose consumption. So the brain, as we all know, the brain uses glucose. Remember, when you're hungry, it's like, oh, my brain ain't working. I'm hypoglycemic. You let me get a candy, you let me get some sugar. So that's where this applies. So this quantifies neuronal glucose consumption and blood flow, which are indicators of synaptic function. So let's talk about, let's focus now on CSF biomarkers. Alzheimer's disease is a neurodegenerative disease associated with amyloid beta plaque and tau neurofibrillar rectangle pathology. So we've known this all along, right? In well-characterized clinical samples, the measurement of beta amyloid 1 to 42, the tau, And phospho-tau, more recently, the phospho-tau in CSF generally allows the diagnosis of Alzheimer's disease. Reduced CSF level of the 42, more specifically now, is the 42 amino acid from the beta amyloid, and increased CSF levels of total tau in Alzheimer's disease have been found in numerous studies with high sensitivity. And more recently, the addition of phospho-tau seems to increase the specificity since normal levels are found in other dementias and in cerebrovascular disease. So, some discussion earlier during the early topics, people were asking, is this Alzheimer's dementia, is this mixed dementia, is it vascular dementia, and things like that. So with this addition of phospho-tau, basically you can see the plain tau can be actually elevated in other dementias. But for this one, it increases the sensitivity primarily with Alzheimer's. And we're talking about Alzheimer's dementia, as mentioned again earlier. Alzheimer's dementia is the more common one. Okay. So, Bleno and his team here found 85% specificity and sensitivity in predicting conversion from MCI to Alzheimer's disease. I think it was Dr. Salazar that presented earlier like an algorithm or a diagram showing a normal person and then has a minimal cognitive impairment and then to dementia. So what we're talking about now is his focus of his study is on the MCI and to the dementia area right here. So who are the ones that are going that are under the MCI that are going to Alzheimer's disease? We don't know that with certainty right now. So they're saying that this could be, helpful in predicting who among these people are going into the Alzheimer's disease. So, although other researchers like Brandt et al. Noted drop in sensitivity to 50%, it's really cold in here. When it dropped, the sensitivity actually dropped to 50% when one biomarker is measured as part of a routine diagnostic test in a memory clinic setting. Perhaps, of course, when you're in a memory clinic, they see all the memory problems. You have vascular dementia, Lewy body dementia, all those dementias. So the sensitivity, of course, would go down because those are already people that have all this established diagnosis of dementia. And also, not only the dementia from what do you call it? Dementia from neurologic, also neurodegenerative diseases. So we talk about beta amyloid, we talk about the tau and phospho-tau. Those are the CSF established biomarkers. So we'll move along on. Do you guys have any question about the previous topic, CSF? No? So we'll go ahead and move on to the imaging studies. So this is an MRI of the normal person. The red arrow right here shows your hippocampal area. And this spot right here would be your medial, let me see if I can show you. The medial temporal area right here. And that would be your hippocampal area. This arrow, this small area right here. This on a normal person. And on MCI, or minimal cognitive impairment, you can see some difference from the size. This one has more fullness, and this one seems a little smaller. And then you have a little bit more atrophy of your medial temporal lobes, which is the medial right here, your lateral right there. And then you go on to the Alzheimer's scan right here. You see that space, more thinning, and of course, a lot worse atrophy on the medial temporal. Okay, and of course, the hippocampal thinning, right here, atrophy, it's a well-known marker of disease progression of Alzheimer's disease. And that's what mentioned earlier, that parts of the brain are more atrophied, more specific to your Alzheimer's disease. Okay. Okay, so we move on to our functional imaging and amyloid detection. So this is using PET scan. Okay, can someone guess from which patient are these pictures right here? This is from one patient, this is from another patient, and this is another patient. Any guess on this? Is this going to be a normal person right here, normal mini-mental state exam, or abnormal? What do you guys think? Huh? Normal. Normal, yes. Normal. Very good. Excellent. So, the first column right here is from a normal individual. This guy had a MMSE score of 30. And remember the chart earlier? MMSE, up to 30, normal. Okay, that we apply here. All right, and this one is on the PIB. And PIB is used to find the amyloid, right? And this one is just MRI for the structure. And this one is the FDG, which, of course, the glucose metabolism and blood flow. So these would be from a normal person. And now you have the milder form of, or stage of Alzheimer's. And this guy had an MMSE of 26. And this guy actually had a, this redness right here, these are PIB retention. So you already have some markings right there. Remember this tracer combines with your amyloid? So you already have some tracers right there. But your MRI is still normal. See right here, it's the same as this, similar. And here is your FDG. FDG is still normal. You have a lot of the metabolism is still intact. And then here comes an Alzheimer's disease patient with a lot more of these PIB tracers. Okay, and here you're having on the temporal lobe, and then now the scan. What do you think of this scan? It's okay, thank you. Yes, you're the winner. Yes. See, you guys are going to be radiologists before we finish here. Okay. So yes, this is all normal stuff. But when you see right here, I put an arrow. So now that's a clue. What happened to the FDG? Remember, this is metabolism. It's less, yes. It's less on the preferential area, okay, of area for Alzheimer's disease. See right here, they're good, less and less, and less the frontal area. And then it also also correlates with your amyloid tracers right here. All right? So is there any question on this area right here? We're good? All right. Moving along. Now we're done. Yes, ma'am.
Back to the X-ray. You said the MRIs were all normal,
Yes?
but you said how the PIB and the FDG are not? I mean, are they three different tests?
They're all using PIB, MRI, and FDG. I guess the point here is these two, the PIB and the FDG PET scans, show the abnormality.
They're different.
They
scans.
already show the abnormal, yes, different scans.
Okay, that's what I was wondering, because the MRI did not pick it up.
Exactly. So MRI kind of delayed, hasn't showed yet, but these two tests already picked up.
Okay, so if they did an MRI and it showed it was normal, I mean, how, at what point do they get a PIB and an FDG?
the same time.
They don't normally go to that next step.
They don't. And actually this is like this, we don't do this in our facility. We do this and we do this. This FDG.
Okay,
But-
so you would literally have to ask for it and hope that your insurance covers?
Yes.
I mean, if you go by the MRI,
Yeah.
then it's normal.
Okay, and remember too, biomarkers are not really ready for prime time in our clinic. So if I see patient in our GEM clinic and I suspect a, MCI, minimally cognitive, we did MMSE and that, we don't go and, let's go a PIB on ya, These are all kind of research. I mean, they're not quite ready out there to say, okay, primary care, if you did a patient MMSE at 26, let's go ahead and, we still have to look at the patient as a whole patient, because it might not be Alzheimer's disease. We still have to go through your basic, remember these are biomarkers specifically for Alzheimer's disease. You still have to go into your checking your B12, your folate, your TSH, your, controlling their blood pressure, diabetes, and all that, and making sure they're not depressed. And if they're depressed, they might need intervention. So, but these are basically research to tell you guys that, there's some stuff available out there that yes, it can be detected, but they're not ready for prime time, although they already established CSF biomarkers. So if you ask me, do you do this in your patients in the GEM clinic? Not necessarily. We'll probably use this very, very seldom in this area. But the point right here, which is a very good point, thank you for bringing that up, that you could have a normal MRI. You already started right here in MCI, but you still have normal FDG and MRI on this area. This one already is showing now the abnormality, when on this PET right here already started in MCI. Okay? Yes?
Dr. Revote, how advanced, that's my question, how advanced are these scans, for the person? How long, are they diagnosed? Are they newly diagnosed? Have they been exhibiting some behaviors for a while? Or
Good question, thank you. So the correlation here, as I mentioned earlier, this one had MMSE of 30, which is normal. If you're trying to correlate that clinically, which is, very good. This one right here, about MMSE of 26. And this one right here is, of course, pretty advanced, probably 20. So that's how you probably like, okay, how do I picture this? I did this MMSE, mini mental state exam, and then I did this, on a patient. What do I expect? This is just a sample. And of course, the sample sizes are smaller, which we're going to talk about that in the future slides. Okay, thank you. Okay, so we talked about CSF, we did the fancy PET scan and MRIs, and now moving along to blood-based biomarkers. So, valid biomarkers in blood is highly desirable because they, you don't have to lumbar puncture to do the testing. Of course, they're available by drawing blood because they have the advantage of being easily accessible. However, there has been little consensus among studies as to the relationship between plasma serum beta amyloid and Alzheimer's disease. The search for potential biomarkers in plasma or serum is complicated by the presence of a number of abundant proteins in our bloods because of the high complexity of the blood protein and probably because of its distance from the pathology, the brain. So novel biomarkers in serum or plasma is still elusive. The identification of blood-based biomarker for Alzheimer's disease has been the area of interest of many research for many years. Investigators at the Alzheimer's Association and the Alzheimer's Blood Discovery Foundation described the state and identified the challenges. So this is the consensus right now. There's basically an ability to duplicate findings in some areas, variability in pre-analytic, analytic, and post-analytic processes. Pre-analytic is like how do you handle the blood, what kind of tube you would use, and things like that. A small sample size of a study group and variability among study participants. So, moving on to more specific area, Alzheimer's disease among Mexican Americans. Let me give you some, I think Dr. Cawthorn already talked about the population or demographics, but let's describe what we're expecting or predicting. So Mexican American population increased by 54% and had the largest numeric change, growing from 20.6 million in 2000 to 31.8 million in 2010, and accounting for about 3/4 of the 15.2 million increase in the Hispanic population. And researchers believe that by 2050, the rates of Alzheimer's will go up 6-fold among Hispanics. This is what we just described, like this. Blacks alone, Asian, and just the others. So the next few slides, what we're going to do is to review some of the studies or research, if you will, that is that are pertinent to the biomarkers. Now, Espanol and his group did a retrospective analysis, retrospective review of 89 Mexican Americans who presented to the University Cognitive Disorder Clinic in San Antonio. And the study group presented at they found that the individuals presented at a later stage of the disease, about 73% at moderate to severe, with only 23% at mild stage. So someone I think mentioned earlier, people are afraid to go see the doctor and evaluate it. There's some reservations as to, well, they might say I have Alzheimer's dementia or I have dementia, things like that. And I think that's some of the things that the reason probably why they present later on, the later stage of the disease. And this finding is shared by other researchers such as O'Brien and Humphrey. And these patients suffered from IADL decline and 56% had a gait and balance problems, have a higher rate of depression, and I'll describe what we just mentioned earlier. So that was Espino's group. Now, O'Brien's team used community-based participatory research, and this one, they had a larger number of sample with 1,069 participants, age 40 and above, and there were 436 Mexican Americans, 633 non-Hispanic whites. They study reported the Mexican Americans with Alzheimer's disease cognitively scored lower. So if you see the MMSE right here, compared to their counterpart, and then when you see the clinical clinical dementia rating right here, against a little higher here compared to the counterpart. And then you have your geriatric depression scale. Again, as we mentioned earlier, the findings of Espino is the same as O'Brien's team's finding, where they have more depressive symptoms compared to their counterpart. Interesting to see that apolipoprotein, we talked about ApoE earlier, and ApoE, for the Mexican American groups, they were only 38% of them had this E4, epsilon 4, and their counterpart at 60%. A remarkable findings right here, 46% with diabetes compared to 14%, and obesity 27% compared to 13%. Now we're trying to compare both categories, okay? So this is Alzheimer's disease, this is Alzheimer's disease. And you also have your MCI and your MCI counterpart right here. And even your MCI, they still basically much higher than their counterpart. This is another group, Leibniz group, examined the ethno-racial differences among African American, Hispanics, and these Hispanic groups are the Hispanics of Caribbean origin and non-Hispanic whites with Alzheimer's disease. They observed a higher rate of hypertension, for the from the African American group, but when you look at diabetes, 20.1%, 15.1 on African American, compared to only 5.3 on the non-whites. So they observed that higher rate of hypertension among African Americans and a significantly higher rate of diabetes among Hispanics. So is it possible that diabetes or the cardiovascular problems that go along with it can help explain elevated rates of Alzheimer's disease in these ethnic groups, these two, as compared to whites? The mechanisms underlying a possible association between diabetes and AD are unclear, but some offer the possibility that the production of glycation end products increases Alzheimer's pathology. So let's just briefly summarize what we saw from those several studies we just presented. Younger age of onset in Hispanics, higher prevalence of diabetes, less likely to carry apolipoprotein E epsilon 4 allele. Blacks and Hispanics are twice and 1.5 times respectively to have Alzheimer's than whites. And of course, I'd like to emphasize that lack of association of that ApoE genotype with Alzheimer's diagnosis in the Latino group. questions? So we'll move on to the biomarker profile among Mexican Americans. So O'Brien used a biomarker multiplex platform that contains more than 100 proteins to analyze 363 Mexican American participants, 49 with Alzheimer's disease and 314 normal controls, enrolled in the Texas Alzheimer's Research and Care Consortium. I think Dr. Salazar mentioned about TARC earlier. Several of the top biomarkers among Mexican Americans are known to be associated with metabolism, such as, see that number 1 right here, it's fatty acid binding protein, glucagon-like peptide, let's see, this one, insulin-like growth factor, pancreatic polypeptide, and here is your insulin. So fatty acid binding proteins are small intracellular cytoplasmic proteins involved in the binding, transport, and metabolism of long-chain free fatty acids that have been implicated in diabetes, obesity, insulin resistance, and the metabolic syndrome. So Alzheimer's disease biomarker profile among Mexican Americans differs from non-Hispanic whites. Markers are also linked to diabetes, obesity, insulin resistance, and the metabolic syndrome. And this suggests that metabolic phenotype of Alzheimer's disease is of significance in Mexican Americans. Apologies for this picture is a little blurry. So you guys saw the FDG pad earlier. Yeah. And so this one is an FDG pad in apolipoprotein E4 carriers. Making you busy. So this is an interesting study by Langbaum and others where they recruited 81 participants from Arizona's Latino community, predominantly Mexican Americans. 11 were apolipoprotein E epsilon 4 carriers and 16 non-carriers who underwent FDG PET. They reported that there is a reduction of glucose metabolism in this area. This is your frontal lobe right here. This is the back of your brain. That's the cerebellum right here. This is your parieto-temporal complex. So they reported reduction of glucose metabolism in brain regions known to be preferentially affected by Alzheimer's disease relative to the non-carriers bilaterally. I thought this is an interesting study because we talk about ApoE epsilon 4 lack of association earlier, correct, with Hispanic groups. But now when you have an ApoE4 positive or carrier individual, and they did this, it showed that, oh, let me go back. These are FDG PET for normal people. They are not Alzheimer's disease patients, but they are ApoE epsilon 4 carriers. They only carry the genes, the allele epsilon 4, and they're normal people, and they are already showing this. So the relationship of ApoE, epsilon 4 allele and Alzheimer's disease Hispanics needs further studies. This study showed that Mexican Americans noted CMRGL, that is your cerebral metabolic rate for glucose, decline among ApoE epsilon 4 carrier. Caucasians, ApoE epsilon 4 heterozygotes were similar to Mexican American non-carriers. And the lower CMRGL or metabolic rate in glucose in Alzheimer's dementia preferential areas were similar to normal ApoE epsilon 4 carrier Mexican American. We hear about CRP all the time, C-reactive protein, left and right. And so several researchers have examined CRP in Alzheimer's disease and observed a consistently significant decrease in CRP. So this is from a normal people. And this is for non-Hispanics, and this is for Hispanics. So they're both, I'm sorry, this is normal, and this is for MCI, and this is for Alzheimer's disease. So both non-Hispanic and Hispanics have decreased CRP with Alzheimer's disease. And that's consistent with whites or non-whites. But in addition, O'Brien's group found that CRP and Alzheimer's disease risk varies according to time and disease progression among non-Hispanics, which suggests that ethnicity plays a role in the relationship of CRP level and Alzheimer's disease clinical outcomes. See, with your MCI, they're almost the same reduction, but when you go into the Alzheimer's disease, much reduced for the non-Hispanic group. So, for our conclusion, validated biomarker can serve as a prognosticator and can facilitate development and monitoring of drugs and other treatment outcomes. Current evidence supports the idea that Hispanics present a diverse biomarkers for Alzheimer's disease. Which and how biomarkers should be used in clinical trials remain unclear. The availability of valid means to detect and predict Alzheimer's disease is fundamentally critical, especially when the future brings preventive and disease-modifying therapy regimen. And biomarkers of Alzheimer's disease are well suited for clinical research. However, their practical utility in daily practice still poses challenges. That's where we are on Alzheimer's disease biomarkers. Have any questions? Yes, ma'am. Thank you for your time.
We can now, thank you very much, Dr. Revote. Very good. We're going to take a break. We've got about 15 minutes. We might get out a little early today. Oh, clap, clap, clap. But they've given us some more refreshments over here. Please drink, eat, drink, and be merry. And if you have any of the paperwork for me, the profile or the for the CEUs, I can start picking that up. We just have one more speaker.
The raindrops are falling, they pitch on their heads. Their uniforms are heavy